think of it this way, you guys. The easiest way to understand how it affects the body is anytime somebody has anything going on in their peripheral vascular system, their heart, their veins, or their arteries, eventually it's going to lead to breakdown, right? If they don't get it treated right. And that breakdown can occur as hypertension or abdominal aortic aneurysms. Any of those things can occur when they have a peripheral vascular disease going on, okay? Now your test that I first gave you guys when I first came in the classroom was a test that covered cardio-arterial disease, it covered MIs, it covered anginas. It had quite a few things it covered in it. So a lot of these things heart failure, a lot of these things I'm talking about, you should already be pretty aware, at least have heard of them. Might not totally understand it, but you've heard of them. Is that correct? Mm-hmm. Okay. So we have to know as a nurse that the blood flow through the peripheral system plays a big role on blood pressure. And how it plays a big role on blood pressure is when we're brand new babies, we have this vascular system that has elasticity, it has nice working valves. It's hot in here, huh? It has all these nice things in our body, but the goal of our body is to age, right? And as we age, our veins and arteries change. And then if we get a disease on top of it, like hardening of the arteries or high cholesterol or anything like this, now we're double whamming ourselves, because age is changing things with just age, and that's a gradual change. But when we add a disease on top of it, it increases the aging process and causes us to have all these symptoms, signs, and need of treatment. What is vasoconstriction and vasodilation? How are they controlled? Well, vasoconstriction and vasodilation are controlled by our sympathetic nervous system. Our sympathetic nervous system, remember when you learned about central nervous system? You learned about parasympathetic, sympathetic. Well, the sympathetic nervous system works in conjunction with the kidney system, which uses the products of angiotensin and renin to cause our blood vessels to either vasodilate or vasoconstrict. And either way, vasodilate will decrease blood pressure through the enlargement of the veins and arteries, and vasoconstriction will increase the blood pressure through the blood flows being constricted, right? Through the diameter of the vein and artery being changed, it's going to cause high blood pressure. The same volume wants to come through those veins and arteries, but they can't because of constriction. So vasoconstriction and vasodilation are controlled by the sympathetic nervous system, okay? Primary and essential. Primary or the word essential are the same words. Primary, essential means the same thing. Hold on, let me turn the other way around. So when we talk about primary blood pressure, we're talking about persons who have a 10 to 20 millimeter mercury difference in their systolic and diastolic for a length of time, and it can be represented or given to them through their genetics, right? They could have inherited it, could be from an illness or an injury, and it requires medication. And primary or essential blood pressure, high blood pressure, doesn't have necessarily organ issues yet. They're not affected yet. There's just this elevation of blood pressure, and it's genetically predisposed. So we want to teach them diet, exercise, stress management before we really slam on the medications. Secondary hypertension is brought on by another system failure or illness. So another system means an organ system within your own body. So maybe your parents don't have high blood pressure, your grandmother never had high blood pressure, but you suffer the worst kidney infection anybody's ever had, and it shuts your kidneys down. Now you have secondary hypertension, because it wouldn't have occurred except its kidneys were the primary effect, right? And the secondary result of kidney failure is high blood pressure. The secondary effect of a myocardial infarction could be high blood pressure. The secondary effect of a coronary artery disease could be high blood pressure. So anytime there's a change in the system and the organ and it alters the blood pressure, that's called secondary blood pressure, okay? Risk factors leading to high blood pressure, which are modifiable. We've always talked about this the last few days. We know anything that you can take away nicely from the body, nicely meaning you can take a cup of coffee away, they might fight you, but you can take it away, right? You can take cigarettes away, you can take alcohol away, you can take salt away. Anything you can take away that is on the outside of the body is a modifiable risk. Anything that's internal in our body is not too modifiable. Meaning if obesity, we can take the diet and change it, right? So that's modifiable. But what about coronary artery disease resulting with high blood pressure? Well, there is a modifiable risk in there, isn't there? We can alter the diet in hopes to slow down the arterial sclerosis and change the blood pressure, right? Lower it a little bit. Yes, ma'am.
There are some, once you have hypertension, you always have it?
Not necessarily. Depends on the cause, and it depends on your willingness to alleviate or alter your patterns of life. Some people can be diagnosed with high blood pressure, and they might be 40 pounds overweight, smoke like a chimney, allow their bosses to get to them, all of that stuff. But we tell them, you have high blood pressure, you're at risk of having a stroke, and they change permanently. Now they have hypertension still on their medical diagnosis, but it's being controlled by diet, exercise, and stress management. And that's how we would list it. Once you have diabetes when you're pregnant, gestational diabetes, you always have diabetes in your medical record. So it's letting the doc know, hey, this person's had it already once, so he's double the chance of having it again. If things are right, they're gonna go into it. Okay, hypertension is, as we defined it, it is a 10 to 20 millimeter mercury difference in the systolic and diastolic. We talked about primary versus secondary. First stage, the systolic blood pressure range is 140 to 159. That is the first stage of hypertension. The second and third, and the diastolic is greater than 90. The second and third stages are combined. Usually the blood pressure systolic is greater than 160 and the diastolic is greater than 100. So in second and third stages, we're really keeping those combined. We almost could call them one stage in themselves, right? Because if the blood pressure systolically is above 160 and the diastolic pressure remains above 100, they remain in that second/third stage of hypertension. What crosses them over into that complete third stage is going over those 160s, over that 100, and also acquiring kidney disease and stuff, puts them into that third stage. Third stages usually are followed by kidney failure, heart failure, things like that. That is usually representative of a person in third stage hypertension. Systolic blood pressure comes from the left ventricle contraction. So we've talked about the heart, we've talked about the atrium, we've talked about the pacemakers of the heart and all of that stuff. Now we're talking about just the left ventricle. When it contracts, it causes or equals our systolic blood pressure, okay? So the systolic blood pressure is caused by the left ventricle contraction. So what do you think the diastolic is caused by? The relaxation of the left ventricle, correct. What does malignant hypertension cause and affect? Anybody hear of malignant hypertension before?
It's like a
No, malignant doesn't mean cancerous. Malignant means it leads to death, okay, but it doesn't mean cancerous. Malignant hypertension can lead to death, and the cause can be it's not uncommon to happen to persons who are having some type of abdominal surgery, and all of a sudden their physiological thermometer regulator, their hypothalamus, it kind of frizzles and gives them this internal temperature over 100, and it escalates their blood pressure, and it's called malignant hypertension. And in the OR, they have to literally sometimes dump ice water into the abdomen and run ice cold IV solutions into the person to try and bring the malignant hypertension crisis down. Usually leads to death. It doesn't matter what age. It occurs more often in children, but it also occurs in adults, very rarely. It's called malignant hypertension. What it is it's a hypertensive crisis that is going to lead to death. So when we have malignant hypertension, we have a hypertension that is above 160 systolically, above 100 diastolically, will not be managed with medications, diet, or stress, and it's brought the person to an unconscious state, and they're suffering the consequences of this huge amount of blood trying to flow through these very constricted veins and arteries. So they're bleeding. They have thrombus and emboli all over their body because the veins are rupturing. And it is a process of impeding death. So even though they had a malignant hypertension, you won't know somebody that's had a malignant hypertensive crisis and survived, because it's an evolution. It starts off with them not managing their high blood pressure, thinking that it's not going to ever affect them, and eventually the body can't maintain its homeostasis or try to maintain its homeostasis anymore, so it surrenders to the blood pressure, which brings the person unconscious because the pressure's too high in the brain. And then it causes small ruptures in the veins and arteries all over the body, so they get emboli traveling everywhere. Let's see. The effect would be death, basically. Strokes, DVTs, pulmonary embolisms, and then death. So it's very, very serious. Yes, ma'am.
So right here it says it's common in black men at 40. So have they been struggling with high blood pressure all this time?
Well, remember, we have a problem with men, right? We have this problem that if it doesn't affect their genitalia, they don't go to the doctor. So African American men, African American persons have higher blood pressure naturally. Why? Don't know. We have to ask that person that created all of us, or that energy that created all of us, whatever you believe in. We have to figure out, when they created us in different dimensions and colors and sizes, why some have this and some don't. But they have, the African American population have a higher incidence of hypertension than any other.
So
And
they have been having it.
they have it, right. So the 40-year-old African American has two things against him. One is he's a man and won't seek his regular medical attentions. And two, he's African American in that high rate of population that has hypertension without treatment, because he doesn't feel anything. He's not feeling bad. He's going to work, he's living his life, he's not having erectile dysfunction problems. He feels great. And then all of a sudden he drops dead. And what we do is we get that 911 call and we go to treat him, and his blood pressure is 260 over 200 and unresponsive. And that's that malignant hypertension. Okay, what are subjective data versus objective data? We can look at our books on hypertension or any of these chapters on any of these things, and under assessment they always tell you subjective data, objective data. So one of the objective data with hypertension is getting the blood pressure and physically reading it as the nurse. That is objective, right? You see the blood pressure once you've gotten it, right? Another one would be seeing any of these things. The nosebleed, the headache, having the person complain of things like that. Those things are representative of being objective data that you're gathering. You can walk in and have the person holding their head like this, and you say to them, do you have a headache? And they say, yes. That's your objective data. You physically saw them holding their head. They could be holding their head for another reason, but this time it happens to be a headache, right? You take their blood pressure and it's extremely high. That is now your objective data as a nurse. You see their blood pressure reading. And then the other thing that you can also do is you want to also measure and record their height and weight. We know that persons who have weight issues tend to have medical issues, and those medical issues also involve cardiac disturbances and blood pressure disturbances. So being overweight is not a good thing, okay? Diagnostic tests for these things, well, for the AAA, the diagnostic tool is an ultrasound. For the high blood pressure, it's an electrolyte panel, as well as a kidney panel, and measurements of the blood pressure consistently. So your diagnostic tool also will be a EKG. You'll want a 12-lead EKG to see the basic heart rhythm at that time before they get into any kind of crisis or permanent onset of high blood pressure. Medical management, we talked about it. Who can't have ACE inhibitors and beta blockers? Who? Why? It affects, keep going. It affects their kidneys. They're more prone to kidney failure when they're on ACE inhibitors and beta blockers. Okay? Any elderly cannot have calcium channel blockers or long-acting calcium channel blockers or diuretics. Why?
Renal calculus.
Well, they develop renal calculi really bad, and why would you want a long-acting diuretic or a diuretic on an elderly who has to use a walker to go potty or can't even get out of bed? I mean, sometimes we give diuretics to elderly, yes, small doses, because their metabolism has changed with age.
Slower.
Their liver doesn't metabolize things as fast as it used to. Their interstitial fluid exchanges between cells and calcium channels and all that stuff is slower, if not even existent anymore. So you got to be wise as to what you're giving. Okay, there is a peripheral artery disease called claudification. Have you ever heard of claudification?
Intermittent claudification.
Intermittent claudification is a process where persons who have peripheral vascular disease suffer extreme leg cramps and leg pain while they're walking. Once they stop walking and sit down, the cramps immediately stop. So it's intermittent leg pain, particularly in the calf area, causing extreme leg pain and cramping while they're walking. And that's called intermittent claudification. And doctors use different treatment regimens to assist with that. But one of them is, usually they're slightly obese, so guess what they have to do? Lose weight. If they have peripheral vascular disease and it's really bad arteriosclerosis, there's not a lot we can offer them except teach them to take frequent rests and elevate their legs. Okay? Let's see. Medical management options, I mentioned those. That is pharmacological. We can use medicines, or we can use lifestyle changes, which involve diet, exercise, stress management, and we can also use, if they're open, we can also suggest that they go to a hypnotist, or that they go to a person who teaches them how to meditate and how to completely surrender all of their stress to sounds of the ocean or things like that. And so a lot of people do really good with that kind of treatment. The drug therapy special considerations, again, based on ethnic, race, and age. We already know that the race that cannot have ACE inhibitors and beta blockers is African Americans, and the population that should not be given diuretics and long-acting calcium, elderly. DVT prevention is, of course, moving the legs around, right? Keep your legs moving around. It's also using the bilateral compression boots. When the patient's going to be in bed for quite a while, you want to put those bilateral compression boots or stockings, whatever you call them, leg wraps on the patient, and keep rotating them, meaning you take them off and let the legs rest for about 15-20 minutes, and then you put them back on, because you have to check the skin underneath it. When I was at a local hospital working as the infection preventionist, I was called in to look at a sacral wound that you could put your fist in and touch her tailbone. And I was looking at it and smelling this horrible smell, but it wasn't coming from her wound. And so and when I got to those sequential boots, I almost leaped through the wall behind me because it was so wretched. So I said to the nurse, how long has she had those on? And they said, since she's been here. I said, she's been here 2 months. Has anybody taken them off and washed her legs? Well, of course the CNA does all the time. I said, well, I gotta look. So I get my gloves on and I peel them off. She had rotting of her tissue on the back of her calf infected. That's what I was smelling. Because nobody had taken them off and looked at them. And so these people are she was a diabetic, so she had a venous stasis what? You almost said it. She had a venous stasis ulcer, which is very, very bad, very difficult to heal, and it had gotten infected. So please, when you have a patient in sequential boots, undo the boots, assess the legs, check the pedal pulses, and document and put them back on. The onset of a DVT, people complain of the same thing. We have a Holman sign we like to ask patients. How does the Holman sign assessment work? We ask the patient to bring their toes toward their face. And when they bring their toes up toward their face, they get extreme pain in their calf. And then we don't say, oop, you got a DVT. We then let the doctor know we've checked the pedal pulse, capillary refill, checked for Holman sign, they're positive. Now we tell the doctor who's going to order a Doppler study and an ultrasound to find the clot and treat. Once they have a DVT, do we put those antithrombolytic or sequential boots on them again?
No.
Why not?
Because it could travel.
You could dislodge that clot. Do you massage the patient's legs and calf? What if they're complaining of extreme pain?
Sorry, elevate.
Tylenol and Elevate, that's right. When do you put the TED hose on a patient? In the morning or after they've gotten up and clean?
In the morning.
In the morning before they take their legs out of bed, because once they take their legs out of bed, edema sets in already. So it's harder to get those TED hose on. The treatment focus, nursing focus of DVTs is to monitor the patient's medication levels. Whether they're on heparin or Coumadin, you need to know their therapeutic levels. You need to monitor for pedal pulses and capillary refills. You need to measure the calf, the girth of the calf, to make sure that it's not swelling bigger, because visualizing it and actually measuring it makes a big difference. So you could be standing there going, no, it's not any bigger than it was, and somebody took the time to measure it before you. So you finally convince and go get a ruler and measure it, and it's twice that size. And you said, oh, I didn't realize that, because you never measured it, so you don't realize that, right? So you got to do those things and document. And then the side effects, the thiazide diuretic. What would be a thiazide diuretic? What would be the side effect of that?
Potassium going
Your
down.
potassium imbalance. What else?
Go to the restroom.
What were you saying?
I said edema, but
We're giving you the diuretic for edema. So the diuretic draws at a cellular level, draws fluid out of the body from a cellular level, so you can have dehydration. Electrolyte imbalances and dehydration are very important to monitor the patient for.
what was the previous one you said? Dehydration, and what was the other one?
Dehydration and electrolyte imbalance, as well as kidney function. You really want to make sure the patients have good kidneys if you're going to give them a diuretic. What happens if the patient's on dialysis, has a shunt, hasn't peed in a year, and you give them a diuretic?
Stand back.
Stand back, why?
Their kidneys aren't working.
No, complete kidney failure do not pee. They have the dialysis and shunt. Do we give them diuretics?
No.
Are you sure?
Oh yeah, you might gut function and everything else, huh?
You do give them diuretics, but you have to give it before dialysis, because if you give it during dialysis, it's not going to work because it'll be washed out of the body. And if you give it immediately after dialysis, you're going to cause the patient to go into shock, because during dialysis, a lot of extra fluid is removed from the blood as well as waste products. So patients that are on dialysis do receive diuretics under a very monitored, controlled dose, and it's usually before dialysis, and I mean a day before dialysis. And we don't measure output, do we? What we'll see is the nurse who's dialyzing the patient will get a lot more fluid than she's ever gotten. I've seen them pull 2,000 liters of fluid off a person before. And I was shocked, because how many liters do we have in our body? 4 to 5 liters of blood, right? So can you imagine 2 liters of extra fluid in your body? Can you imagine that? I can't imagine that. What is strep throat, and what happens to the heart if it's not treated? Pardon me? Not the muscle of the heart.
Valves.
What does it do to the heart?
It makes the valves dysfunction.
It causes dysfunction of the valves, but it also, the bacteria or the strep eat a hole in the heart. And so the treatment for a patient with the history of rheumatic fever, hear that word before? Is they have to stay on antibiotics the rest of their life, because they have to prevent any sign or symptom of infection, because their heart already is jeopardized, okay? And they are prone to have problems with later their kidney function because of long use of antibiotics, as well as having their peripheral vascular system altered, because the heart has a hole in it. It's not as an effective pump as it would be if it was all okay. Yes, ma'am.
What if they
Sir.
susceptible to like superbugs and whatnot, since they are taking antibiotics?
I like that you said superbugs. That tells me you're keeping up with science. So, you know, there's this big push in science right now. We don't want you to get antibiotics, and you should, as nurses that are now becoming educated persons, you should educate your family members that they, every time they have a sore throat or a gunky eye or tummy ache or vaginal infection or diarrhea, they do not need to run to the doctor and get an antibiotic. They do need to monitor themselves to see what's happening. If you have a sore throat, sudden onset, extreme pain for 2 or 3 days, no fever, it's most likely a viral and you don't need anything. If you have sudden onset extreme pain with pus and fever, it could be a bacterial infection, and you should get a doctor's appointment, but not get antibiotics until the doctor cultures your throat and comes back with a positive culture result. So the doctor, if he's keeping up in science, he's going to say to you, I'm going to culture your throat, send it to the lab, and give you a prescription for antibiotics. I don't want you to start them until I call you and tell you the culture's positive. If the culture's not positive, you can throw the prescription away. What people do is they go get the prescription filled, they wait for the doctor to call, they miss the phone call, they start their antibiotics. Then finally the doctor and them stop playing phone tag, they reach each other 4 days after starting antibiotics, and the person says, okay doc, I'll stop the antibiotics. They stop the antibiotics. Now what happens is all those little bacteria that were susceptible to that antibiotic, their outer shell was being destroyed, so the inner replication process couldn't occur. When you stop the antibiotic, you allow all those free-floating bacteria that hadn't been altered yet to become resistant to that type of antibiotic medication. And we create super infections and superbugs. Next time you take that antibiotic, it will not work at a dose that is appropriate. It'll have to be increased or brought up to another generation of antibiotics.
So how do they know when the body is acceptable for that amount of?
By culture. Cultures are the only way that antibiotics should be prescribed. And you're going to be working in the field with patients that have...
They don't do that. Like if you take your kids to the doctor, they just give antibiotics. They don't test their culture before they.
Now that you know what's supposed to be, you tell the doctor, I don't want to start them on bubblegum amoxicillin until the culture comes back. I want my son or daughter's nose cultured. If the doctor says they have a sinus infection, get the nostril cultured. Get the ear cultured. I had a girlfriend that's kid had an ear infection for a year. The doctor kept giving them numbing medicines, antibiotics, numbing medicines, antibiotics. I said, get her ear cultured. I've never heard of that. I said, just say it to the doctor, see what he does. So she went in and she said to the doctor, I want my daughter's ear cultured. He said, I've never heard of that. She said, just do it. Humor us. So he cultured her ear. It came back with H1N1 flu in it. So this little microorganism had settled in her ear and was causing inflammation. It wasn't going to get better with antibiotics. The flu doesn't need antibiotics. It needs the proper treatment. And with the proper treatment, the little girl's ear was preserved. But she could have lost her hearing and could have become inoculated to medications and it create a superbug.
Wow.
So you really have to see, why is this medicine not working? Why are you continuously sick? Get a culture, get a blood culture, all of that. Make sure people know what they're doing. What happens with the strep throat? If it's untreated, it travels down to the heart. It causes an erosion of the valves and a hole usually proceeds that erosion. And once the heart is compromised, it has to be treated like a baby, and you have to treat with antibiotics constantly, which now leaves the person prone to having a super infection because of their lifelong inquiring or taking of this antibiotic. Some of the bacteria in their body, microorganisms, are altered by the antibiotic. But some of them are becoming resistant or super and creating new microorganisms we don't even know how to identify. HTN crisis, what does HTN stand for? Hypertension crisis. What you usually get with a hypertension crisis is a person that has been not very compliant with their medications. You have to find out when they're not compliant, why they're not compliant, correct? You don't badger them. You find out why aren't you compliant. Most of the time it's financial. They can't afford the hypertensive medicine, so they're taking their dose, that one pill, and cutting it in little quarters so they can take one pill a week. So they take one little piece of it a week. And this is very serious. So, you know, that's why Obamacare came in and all this stuff, is because they're trying to control the cost of doctor's visits, the cost of hospital visits, and the cost of pharmaceutical medication. So it's very expensive when you have high blood pressure, because the pills for cardiac and high blood pressure are very expensive in and on themselves. So when you find out what's going on with the patient and the patient having hypertension crisis, and you find out they're not taking their medications as they usually should, the next thing you need to ask is, why aren't they taking their medicines? Is it financial? How can we assist them once we get them well out of this crisis? Can we ensure that they will be taking their medicine on a regular basis? Because we want to prevent another crisis which could lead to a massive stroke. A hypertensive crisis damages the kidneys each time it occurs. So as they have more crises, the kidneys are worse and worse, and it predisposes them to a massive aneurysm either in the aorta or in the cerebral arteries, cerebral being brain. So you have to really make sure patients are educated, taking their medicines, watching their diet, watching their stress. And when you get them in as a hypertensive crisis, if they are one of those patients who has been obedient, who's altered everything, and now they're just having this hypertensive crisis, and they're saying, why? I don't eat salt, I watch my diet, I take my medicine, I walk every day. Well, you know what? Let's find out what your history is. Did your mother or your father ever have hypertensive crises or strokes? Because if mother or father or grandfather or anybody has had strokes in that generation, the hypertensive crisis could be a precursor to them having a stroke. So then we want to educate them on signs and symptoms of a stroke. Anytime they have a hypertensive crisis, it can lead to a stroke. So treatment is essential. Somebody's thing is making a beeping sound. That's just a silly question right there. Okay, what effects does Lasix have on the body? It's a diuretic, but what are the actions? What is the action of Lasix, furosemide? What is the action of it? What is its action? Well, you're talking about how it works, but what's the action? We know it goes through the kidneys, we know that it's a diuretic, but what?
Angiotensin, comparing it to angiotensin 2, is that
You're getting too deep. but you got
Makes you
it.
go to the restroom.
It removes excess water. So Lasix or furosemide primary action is removal of excess water, okay? The Lupa Henley and yeah, that's all how it chemically alters, but the end result is removal of excess water. Okay, let's see. Oh, sure. Come back in, it's 1:45, come back in at 2. Necessarily is not on the test, okay?
Oh, I missed that.
It's in like 360s, okay. So if you're a male and you're over 40 years old and you've been smoking, you are highly susceptible to developing Buerger's disease. And Buerger's disease is a thrombophlebitic reaction to smoking. Smoking is a vasoconstrictor. And through the smoking, through the artificial ingredients of nicotine causing vasoconstriction, little clots begin to develop. And you get these multiple little clots, especially in your wrists and your ankles and your knees, which cause clotification. Clotification is the obstruction of blood flow, correct? And this obstruction of blood flow is directly related to little emboli, little blood clots. If you get them in your wrists, you're prone to having cold hands, pale hands, and getting necrosis or gangrene of a finger or your hand. So Buerger's disease onset is caused by smoking. Men who are people who are men and 40 years old or older smokers are more susceptible to it. It's a thrombophlebitic disease. It causes the creation of emboli in all the veins and arteries and capillaries, which causes intermediate clottification. A person who has Buerger's disease and decides, oh, maybe I need to exercise, that's why my wrists hurt and stuff. They're noticed that in the heel of their foot, as they start walking on a treadmill or jogging, that they get these horrible cramps in their heel of their foot. And that's clottification of the heel of the foot. And it's not plantar fasciitis. So if you go to the doctor and he says you got plantar fasciitis, you better really pay attention to every symptom you've been having before reporting your heel, because you'll give them a better picture. So you would be telling them, I felt fatigue, I have a lot of pain in my joints, my hands are always real cold even though it's hot outside. If I just started eating better and exercising, now I'm having these cramps in my heel of my feet. Well, that's intermediate clottification and caused by all these blood clots forming, and the forming of these little mini blood clots can eventually become bigger blood clots because they get stuck right where they are and then they get built up. And the bigger blood clots can cause complete obstruction, and then the person loses their limbs. They lose their fingers just like a diabetic, but they're losing them not because of nerve damage from diabetic sugar lack of control, but they're losing them because of nerve damage because of lack of oxygen. Because when those veins vasoconstrict, again, they cause this sudden decrease of blood flow to the areas that need that blood flow and that oxygen, and the blood flow becomes stagnant, and so then they're creating all these clots. So once the constriction stops, they have clots still in the way. And the clots are what ends the person's life, because eventually they've lost their hands, their feet, their legs, and then they've thrown a clot and had a pulmonary embolism or cerebral embolism. So Buerger's disease is directly related to smoking. Men who are over 40 and smoked all their lives are more prone to it. It causes mini clots all over the body, particularly in the wrist, ankles, and knees. It causes clottification, intermittent clottification in the heel of the foot and the leg and all that with exercise and activity, okay? The treatment is quit smoking, and then be on fibrolytic medications, and also eventually you have to be on vasodiuretics as well. Okay, another disease that is circulatory related that you can develop from a thrombophlebitis response is Raynaud's. This one is more prone to be in women who are 25 years or older. And Raynaud's is very patterned, very much the same. This person will have been a secretary and they notice with all their typing that their wrists hurt and they think they're getting carpal tunnel syndrome. So they pop their wrists and they try to feel better, and in doing so they look at their hands start getting spotty and feel very cold. They also notice when they go outside, if the temperature is cold, their hands really hurt bad. Raynaud's disease is a sensitivity to cold. It causes very pale, cold hands. And the most common complaint is the sensitivity to cold. And it is a thrombophlebitic process, therefore it can cause blood clots as well. The treatment plan for this one is different. They do a lot of blood tests as well as a rheumatoid factor blood test, and they're looking at your immune response. And on this one, sometimes autoimmune inhibitors are given to these patients to help them not have this internal response to their own immune system, because it's thought right now to be a self-immune attack. It's thought to be in the class of rheumatoid arthritis and other things like that. But Raynaud's is usually first established by a thrombophlebitis episode. And then the patient will start complaining of sensitivity to cold, their hands are pale, their pulses can be different in their hands, and they can get to the point so severely that they can't even move their fingers. So it's very important that they seek treatment and get on the medical management for it. What was the other thing? I was asked before you went on break to give you guys a type of study sheet, and I was told that you guys are usually given study sheet words. Well, I've not ever created anything like that, but this is your test right here. And there is nothing more in between. I'm looking through it as you guys take breaks to make sure I'm not missing anything, and I just saw one thing that I need to still mention, and that would be medications. As we were talking about medications, you would need to know with somebody with stage 1 hypertension, so we go back to stage 1 here, what is the drug of choice? And your choices for that is, so I don't spell them wrong, these 4 drugs, you need to look those up and determine from your reading and learning from the information which one is the drug of choice for initial treatment of stage 1 hypertension. Okay, so that's something important to know. What else was I looking at that I wanted you guys to know about? Minoxidil. But as far as all this other information, I don't see it on your test. So I'm just sticking to what you need to know right now. If you have a patient, when we're talking about thrombophlebitis and all these inflammatory processes of the veins and arteries and capillaries, we know that when the veins and arteries and capillaries inflame, that the blood flowing through them can be constricted and can form clots and such. So we are monitoring the patient who's complaining of pain, pressure, redness, and swelling in their leg, right? We measure it to get a preliminary measuring, and we usually measure at the highest point of the calf area because we're watching for increased edema. We also want to do our assessment. So we get our measurement, we check our pedal pulses, we get our capillary refill, and we get our common blood pressures from both arms. We get their list of subjective feelings, so they have pain, they're complaining of pressure, they're complaining of heat feeling in their leg, and when you look at it, it's reddened and swollen. So that's your objective information. But now you have to figure out what could it be, because it could be anything from a bug bite to a blood clot, right? So how do you determine what is going on with that person's leg is by doing a very simple test we talked about before you went outside, which is called the Holman sign. And we ask them to bring their toes up toward their face. And when they have extreme pain behind their calf, doesn't always mean they have a DVT. But along with these symptoms and a decline in the palpitation of their pedal pulse, maybe a longer capillary refill, we are now going toward a DVT, aren't we? So what is your initial nursing priority on somebody who's had all of those signs and symptoms and a positive Holman's test? What's the first thing the nurse can do for that patient?
Stabilize the leg. Elevate so it doesn't travel.
Elevate.
Medication.
They make you keep still.
They make you keep still. Why would you want them to ambulate?
Because you can move it.
Why would you want them to ambulate? Your thought is there because they've sat so still they've created a clot, right? But if you have them ambulate, what's going to happen to the clot?
It can
It's going to dislodge. And believe me, they travel very fast from the calf through the lungs to the brain. I witnessed it. So, with my husband. So, what your first initial thing would be is you've measured the calf, right? You've palpitated for the pulses. Could you listen with a Doppler posteriorly and anterior? Would that be something that you would be accessible immediately on your floor? No, so it's not realistic, right? And would you measure the patient's calf and thigh circumferences? Do you think?
Yes.
Yes, we would measure both areas because if we know that this is a normal range and tomorrow we get a bigger girth, what do we know about the edema? It's worsening, right? You may not have gotten a pitting increase, pitting edema 0 to 3 or more seconds, but you've got a spread upward. And that is a sign of more occlusions because now the edema interstitial fluid has nowhere to go because of this occlusion that's either gotten bigger or occurred more frequently than we thought and is now obstructing interstitial fluid. So you measure the thigh and the calf, and that is your priority nursing assessment along with the positive Holman's that helps you determine that this is in fact a DVT, okay? Now let's talk about what is your nursing treatment for that patient.
For what?
The patient that has a positive DVT. So what do you think is one of the first things you would do?
Medication.
Just think logically.
Put them on blood thinners.
If you had the right, very good. You don't have the right, so you follow the doctor's orders, administering fibrolytics, which break down blood clots, and also administering diuretics if need be to help bring off that extra fluid. How about pain? Do you think they're going to be in pain?
Yes.
Yeah, they're going to need some kind of pain management, and usually it's narcotic at this time. And they're going to need a lot of self-reassurance because they're scared. Because the doctors just told them, don't move. And if he doesn't speak really clear English, like a lot of our doctors, they say, do not move because this will go here and do your heart and lungs and you'll be dead. And the patient's like, what? And they walk out and they fall on you. The conversation falls all on you because now the patient wants to know, what did that doctor just say? Am I going to be dead in a minute? And you have to educate them. You have a clot, it's in the calf area, we're going to keep you still. What about the other leg? Are we going to put a sequential boot on the other leg that doesn't have a clot?
Yes, to prevent.
We want to, right?
Why is that?
Why do we want to put it on the opposite leg? Because they've already got a clot in the other leg, so we want to really prevent it from occurring in the opposite leg. So we are doing lots of monitoring, lots of assessments, lots of palpitation. They're on a fibrolytic medication, they're on vasodilators usually, and they're usually on a diuretic and narcotics for pain control. You also have to watch them for temperature. because it could go into a cellulitis, and a cellulitis could cause them to lose their leg. Cellulitis is pain, swelling, and redness in the tissue. It's an infection in the cells that make your skin. So it's called cellulitis, very serious. Okay,
Ms. Deborah,
Yes.
So if they already have a clot on one of the legs, do you still put like those,
Ted hose?
no, the professional stocking?
Uh-huh. What about it?
On the other leg?
Of course.
Okay.
Depending on what your doctor's educational knowledge is and his beliefs and treatment processes, you'd want to encourage him to make some sort of decision to protect that other leg. So you're putting on a TED hose on it. If you put a TED hose, would you use a sequential boot on it too? You could. Some doctors are really aggressive and want that. Some doctors think the TED hose is enough and make them move their leg around. Well, I don't like that. I always remind the doctor that we want him to stay still for the first few hours of fibrolytic give medication at dosage until it's at the level it should be, where we know it's starting to break apart that clot. Is heparin a fibrolytic? Yes, it is. So when patients are on a fibrolytic medication such as heparin, which they'll be on a heparin drip, it says heparin drop here on purpose because on the test it asks you a specific question using the word heparin drop. So it should say heparin drip, but it uses the word heparin drop. What is one of the blood studies we must look at before continuing their heparin? When they're on Coumadin, what do we monitor? PT and INR. When they're on heparin, what do we monitor? Their bleeding time. We monitor their bleeding time. And it's called their bleeding time because what they're doing is literally taking a drop of blood and dropping it into a solution to see how it accumulates itself and how long it takes to drop to the bottom. If it doesn't accumulate to itself rapidly and drop to the bottom, the person's more likely to bleed. So if it rapidly joins itself in its one drop and starts to drop to the bottom and settles, then the person is forming clots and not going to bleed to death. So we look at their bleeding time always. Heparin is a fibrolytic and causes the body to mimic and produce the fibrin antigen that breaks down the clot. So you're looking at their bleeding time. Warfarin or Coumadin, we're looking at their prothrombin time and their INR. Okay? What else do you guys need to know here?
Are we gonna get our test today or?
Yeah, I'll go down and get it. Don't panic. Do you want to know this stuff, or I mean, we'll get it done.
I'm just asking.
Yeah, no problem. I don't mean to insult you. I'm just saying we'll get it done. I just want to make sure you have everything. Okay, here's the last question I'll give to you guys. Your patient presents in the ER with sudden onset of dyspnea, tachycardia, sweatiness, and let's say orthostatic hypotension. What most likely is this patient suffering from? Kind of embolism. Pulmonary. Remember, we're in hypertension. We've talked about pulmonary embolisms, aortic aneurysms, thrombophlebitis, Burgess disease, Raynaud's disease. So don't bring anything out of that conversation into your choice. Look at what the choices are. If we talked about it, it's one of those choices. See? So don't, they're in shock. That's definitely signs of shock. But right now, why are they going in shock? We have to know that so we can fix the problem. And in this subject, they're in shock from a pulmonary embolism. Okay? And I think that'll cover the whole thing. Oh, your math. This is what is the math suggestions on the test. You need to know how to convert grams to milligrams, pounds to kilograms.